I learned when I first came back home, is that working right? Is that everybody hears me okay? Is I worked with Jay Malmquist for several years, as many of you know, and Jay lectures a lot, and one of the things that Jay taught me was if you want to kind of focus your practice on something, go out and lecture about it, because the more you lecture about it, the more referrals you get in that regard. And 8 years ago, I made a tragic mistake, I think, because I started lecturing about medical emergencies. And we actually have 911 on speed dial in my office, because every time one of you has that sicko guy that needs, 18 teeth out and is scared and wants to go to sleep, and his physician is worried about him having it done, you send it to me because I lecture on medical emergencies. So just because they're sick, you don't have to refer them to Steve Beadnell. The other day I had a patient, I actually treated him yesterday, but I saw him about a week and a half ago for a consultation. 81-year-old guy in a wheelchair, barely can speak, just all kinds of medical problems. If there's a problem to have, he has it. And what did I do when I saw him? Certainly consult with his physician about his medical problems. I called him up, I said, hey, I'm seeing Mr. Miller, one of your patients, and he needs some teeth out, and I just wanted to check on his medical status. And I swear, the first words out of his mouth is he still alive? That's not a good start to the day at all. Anyway, so just because I lecture on this doesn't mean I like seeing the patients that are going to give me medical emergencies in my office. So we will review today, try to go through all the material in the 3 hours we have. Like I said, we'll take a break in the middle. There will be a couple commercial breaks or court timeouts because it's actually being videotaped for my mom that couldn't be here today. They're actually videotaping it for some reason. Anyway, medical emergencies. Headaches. Our headaches are going to get worse. The baby boomers are getting older. The population that's over the age 65, we're now in the 2000s, 13%. Over the next 30 years, that number is going to go up some 75%. So as the population ages, we're going to become more inundated with sick patients in our office and much more likely to have medical emergencies occur. The other thing that's going on is medicine, unfortunately, is getting smarter and smarter all the time. And they make it so every patient with almost any disease can now stay alive for many years. And so modern medicine throws all these patients at us that maybe 30 or 40 years ago would have died early on or not bothered going to the dentist because they were poorly compensated. But today we can treat them, keep them alive, and I'm impressed all the time at how many organ transplant, both kidney and heart transplant patients that I see all the time, and dialysis patients, and a variety of obvious, significant medical problems that are going to impact the likelihood of having medical emergencies. And that's only going to get worse in time. The other thing in the United States anyway is we're a pill-laden society. It's incredible how many people take drugs. This is very old data. This is from 1982. But the slide is so great, it just shows the point that everybody takes medicine. I never see patients that aren't on some sort of prescription medicine. It may be something as simple as tetracycline for their acne, but it impresses me how many patients I see that have a 1.5-page list of medications that they're taking from their physician. And obviously as we get older, a higher percentage, and the number of medications, that's in the over 65 age population. The mean number of medications, prescription medications a patient takes is 14. And that's a little scary. And a lot of times you don't know that because they don't list half of them, right? The patient I saw recently pulled his tooth and he bled a lot, and when I started talking to him afterwards, he goes, well, yeah, I do take that Coumadin. You kind of forgot to write that on your medical history. So, it's really going to be more and more of a challenge. This is the patient that, the nice general dentist that referred him to me said, Steve, I know I send you all those just horrendous looking teeth. They're hard to extract. They're in the sinus. but I got a simple case of immediate dentures. I already made the denture. I just want to have him pop over to your office and have you do the extractions for me. This is actually John Smith before he had a reconstruction. He's gone, that's too bad. But you know, relatively easy dental management. I mean, we're going to pull those teeth, they're all single-rooted teeth, no big deal. And so the patient shows up to my office and brings his nice medication list, which shows he takes clonidine and nifedipine for his chronic hypertension and coronary artery disease. He's on prednisone, steroid, and a few inhalers down here for his steroid-dependent asthma. And he is on insulin for his insulin-dependent diabetes. So suddenly the relatively easy procedure becomes quite complex because, of course, he's a dentophobe that wants to go to sleep to have it done. So, you know, I see many patients like this where this part's real simple, this part is real difficult, and definitely puts him at marked increase to have some sort of medical emergency in our offices. So we want to prevent problems, and it's going to get, the C's are going to get rougher as time goes on, only because the population is aging, we're keeping more sick people alive. In order to prevent medical emergencies in our office, we have to recognize what's wrong with the patient. You know, this is an old book, Physical Evaluation of the Dental Patient, trying to teach dentists how to do a history and physical like the physicians do. And certainly I don't think that we need to be able to function at that level in a typical dental practice, but we do need to kind of be aware of what's going on with the patient. The one thing that I think is most crucial is having a good medical history. There's nothing more frustrating than Mrs. Jones getting to my office after you've done 13 restorations on her and a little bit of perio surgery. Now I'm going to pull out a tooth or two for her, and she can't remember her medication list. And so I call your office and I say, hey, what meds is that patient on? And you don't know either. And you've just done 5 appointments with the patient. So a good, accurate medical history, this is actually my medical history, don't bother trying to read it. And it's actually two-sided. The other side has even more questions on it. And a good, thorough medical history will keep you out of a lot of problems. It allows us to know what problems they have, ask them a few questions about, you know, have you ever had chest pain, that kind of stuff, review of systems. And real important is medications and allergies. We need to know what type of allergies, you know, it's not just I'm allergic to the little blue pill, it's we need to know what that medication is. So a good medical history gets us in a position where we can prevent a lot of problems with the patients. Physical evaluation or exam on the patient. You know, I recommend every patient that you're going to administer a drug to, that you take vital signs on the patient before you treat them. In my office, we take it before we treat them and after we treat them. And vital signs, at a minimum, the blood pressure and the pulse. Not so much respirations and temperature, but you know, blood pressure and pulse, I think, are important to know on the patient, just to have a baseline, if nothing else, of where the patient was when they walked through the door. You know, we do a head and neck exam to some extent on every patient, if nothing else, just by a quick observation. And don't underestimate your ability to look at the patient. And, you know, if they're having trouble walking in the office or they're breathing heavy from walking from the parking lot, you know, you have to register that something's wrong. And what's wrong with this patient? Comes in, just needs a single tooth out, no big deal. It's just number 12. I can pull it out in about 45, 50 minutes. I'm slow. Not really. But what's wrong with that patient? He's jaundiced. This patient is a big-time alcoholic, has big-time liver disease, and you know he's jaundiced. It usually shows up in your sclera early on. And he doesn't know he has liver disease. He doesn't know he probably has some sort of coagulopathy and won't metabolize the drugs we're going to give him. But don't underestimate your ability to just kind of look at the patient, and don't ignore those things when you do see them. If you're going to record the vital signs, do it accurately. Take the time to train your staff, or in most cases for the staff to train the doctor on how to take good vital signs. How we do it in my office is we buy the automatic blood pressure cuffs. You can buy these down at fries down in Tualatin. If you buy the cheap one, I think they're about $69. The expensive one is about $89. And they work very well. They're foolproof. They take the blood pressure for you. If you're going to take the time to take the blood pressure with a manual cuff, there's certain criteria. You need the right size cuff. The cuff needs to be about 1 inch above the anacreta fossa. The arm needs to be relaxed. It needs to be at heart level. And you need to lower the manometer slowly. You know, if your assistant can take a blood pressure in 10 seconds, they really didn't do it accurately. But like I said, this is the way to do it accurately, is buy one of these little cheapo machines. I mean, we've been using them for a little over 1.5 years, and they hold up pretty darn well. What we mainly use in our office is, of course, the big machines. I mean, you don't want to buy one of those because they're $5,000 or $6,000. But the abuse that we give them, if we're going to take a lot of blood pressures, we actually use this machine. With the little cheap $89 one, and we've been using them in my office for over 1.5 years, and really have not had to replace any of them. They're very reliable. When we look at prevention, we need to assess the risk. And when we were in dental school, this is what we talked about is, you know, the American Society of Anesthesiology classification, which don't worry about that. I mean, I actually have a dentist every now and then calls me and says, well, what ASA classification would you put this patient in? And, you know, list off their medical problems. And that really isn't super important. You know, don't get into the nuances of what we try to memorize in dental school. What we really want to know is the patient mentally and physically going to be able to tolerate what we do for them? You know, do they have medical problems that are present that are going to put them at increased risk to have an emergency in our office? Or is it going to modify how we need to treat that patient? That's really what we're thinking about. And, you know, do we need to refer the patient to someone else that can handle them better? Or do we need to consult with the patient's physician? And one thing we don't do nearly enough in dentistry, and I'll beat on this a little bit today, is we don't use enough drugs. You know, we're trying to be a drug-free society and, you know, not use drugs. But how hard is it for you to work on the nervous Nelly in your office? It's very stressful on you, and it's extremely stressful for the patient. And if you increase their stress, you're going to markedly increase their risk of having a medical emergency. If you don't own this book, you need to buy that book, Dental Management of the Medically Compromised Patient by Little and Fallis. It is a Bible. I use it all the time. Some of the times when you call my office and say, you know, I have this patient with such and such a problem, how do I manage them? If you'll listen real carefully on the phone, and if you have Sprint, you'll hear the pages ruffle as I flip through this book. And get to the page, and it is an excellent reference for you on what to do with a patient, what to be concerned about based on what medical problems they have.
Who's that publisher?
Mosby.
Thank you.
It's available in the bookstore upstairs, or on the second floor. The other thing we need to look at to prevent problems is what treatment modifications do we need to do on each particular patient to avoid medical emergencies. And that's really what that book will do for you, is it will enumerate those for you and make it very succinct and easy to understand for us young dentists. It's not a real heavy medical textbook. I know every now and then I get the call from the dentist saying, what internal medicine book should I buy? Boy, don't buy an internal medicine book. When I read it, I go to sleep and don't understand it. I mean, that book is absolutely excellent. But what treatment modifications? You know, the thing that I very strongly advocate is that we look at using more anxiolytics in the nervous patients. A relaxed, calm patient is going to be much less likely to have any type of medical emergency we're going to talk about today. Obviously, the most common thing we see in our office is syncope, which is directly related to their level of anxiety. You know, and this is kind of standard stuff, early morning appointments, short appointments. Don't let them wait and worry in your waiting room forever. Adequate pain control, which means good local anesthetic with vasoconstrictor. You know, that old thing about, oh, don't give epinephrine to the heart patient, or don't, you know, to the stroke patient, and you have to worry about the vasoconstrictor. If you want to see a patient's epinephrine level rise, don't get good anesthesia. Hurt them. and their epinephrine level will go through the roof. The amount of epinephrine we're giving those patients is minuscule. So good local, using nitrous, and manage post-operative pain. I mean, not all medical emergencies occur in your office. Some of them are at home when they're writhing in pain, after you do some procedure that's going to hurt them. Give people narcotic pain medicine. You're not going to get them addicted by giving them 12 Percocet. We're all afraid, in dentistry, I think we're afraid to give people medicine. We're afraid to give them Valium ahead of time. We're afraid to give them real strong narcotics for afterwards. But short term, those are not really a problem for the patient. Emergency care, how do we prevent problems? We're prepared. We become Boy Scouts. Murphy's Law says if you don't have it, you'll need it. And if you have it, you won't need it. And that's what we need to do in our offices, is have all the equipment and drugs and everything in place, and the training of our people in place to be able to respond to the medical emergencies. And then the big guy upstairs makes sure that you don't have them happen in your office. Murphy, make sure you don't have them in your office. Good training. Everyone in the office, and I forget exactly what the Oregon Board of Dentistry requirements are on CPR, but certainly everyone in our offices takes basic life support. That's a very great class. It's going through some changes this year that I think are very positive. But I would, especially for the dentist in the room, consider taking advanced cardiac life support. In the old days, ACLS was a very difficult class. It was very intimidating. And when I first took it, I sweat bullets worrying about taking the course. Today, it's very user-friendly. It's very much to help you respond to medical emergencies. Most of it cardiac in origin, but it really refers to almost any medical emergency management. Teaches you how to ventilate patients properly, how to assess patients properly. So sign up for an ACLS class. They're really not that bad. CPR, we all take CPR, and I don't know how many of you do it like I do. I call the fire department, and they send over a guy, and he comes, and he's good looking, and the gal's in the office. Is that politically correct? Is that okay? My staff in the office, don't complain on your little sheet about I said gal, sorry. The staff in the office likes it sometimes because the guy that comes over just kind of whips through it real quick and goes over a little bit with them, has them maybe practice for 2 seconds and gives them the test, but doesn't even make them take it. He just goes through and goes over the answers with them. Does that go on in your office? That gets kind of pencil whipped a little bit. I don't like that. One thing you want to think about next time you take a BLS course is statistics show that you are much more likely to do CPR on someone that you love than someone you don't know. So you want to be good at CPR, not just whip through the class, pass the test, and get out of here early today. Learn CPR well. Equipping our offices, certainly in a dental office, you don't need a big crash cart with a bunch of fancy equipment. But there are a few things that you need to have. And I think over the years I've actually kind of pared down what I think is reasonable for you to have in your office. And the primary things are just a way to give oxygen, a bag valve mask device, some way to deliver positive pressure to the patient that's not breathing, a little pocket mask we'll look at in a second, suction with tonsil tip, and you need some sort of portable suction. Because some people have medical emergencies in your hallway or in your waiting room. So how do you get the, if you just have the chair side suction, unless you've got a really long hose, it won't help you. So I think it's real reasonable to have some sort of portable suction. It doesn't have to be an $800 suction. You can have a $60 or $70 suction apparatus made by Laerdal that works extremely well for medical emergencies. Syringes, IV equipment, McGill intubation forceps, we'll look at all this stuff. Some sort of way to give them oxygen. If you have a portable oxygen system, your suction device can be one of those dual vac suctions. They're a little bit spendy, but they work very well. It's a Venturi system that works off the oxygen pressure, and probably many of you have them in your office. But I think they're pretty spendy. They're several $100s rather than under $100 for the little simple ones that you can buy. These we need in our office because if we need to respond quickly to the emergency out in the waiting room or a patient passes out in the parking lot and they need to have ventilation, the barrier that we want to have, at least in the year 2000, the barrier we want between us and the patient, these little pocket masks are handy to have. Everyone should have in their office a bag valve mask. If you have a patient that becomes apneic, they're not breathing, and you're doing ventilation, the old thing we learn in the old BLS class where you pinch their nose and breathe in their mouth, you want to avoid doing that if you can, just because of contamination of you and the patient. And so everyone should have a BVM bag valve mask device in their office. And you can don't buy the fancy $280 one, because chances are, if you buy one, you'll never need it. And so you can buy a disposable one that's about $30 from Southern Anesthesia and Surgical. And all the names I mentioned, if you need a phone number or want to know how to get a hold of them, just call my office and the staff will be able to give you the phone numbers for those people. Some sort of compact suction, like I said, I have electric and battery powered ones. You don't need to buy anything that fancy, just a little handheld one would work fine. And obviously some sort of suction tip, the yank hour or tonsil suction that goes on it. You need to have some ability to start an IV, if nothing else, just a tourniquet, but it's reasonable to have an IV set up so we can actually run fluids in there. You may not be able to do that, but your next patient in the waiting room may be a physician and be able to help you manage the medical emergency in your office and actually start an IV, and of course, syringes to give the drugs. And that's really all you need. It's a very basic kit, nothing real fancy. You don't need to be able to defibrillate patients or anything in the average dental office. Other things you might consider is a cricothyrotomy set. There's a variety of them on the market today. All you really need is a 15 blade. They work just fine. But some sort of way to open an airway if it becomes totally obstructed in a severe allergic reaction or something. Artificial airways, the oropharyngeal, nasopharyngeal airways, everyone's kind of familiar with, I think. Those are reasonable to have. And if you're doing some sort of sedation at all in your office, and there's a chance that the patient may need to be intubated, obviously you need a laryngoscope and endotracheal tubes of a variety of sizes. But for most of you certainly don't need that. But this is something you ought to buy. It's a McGill forceps. You can get them through Burkhardt or anyone else. They can order them for you. They're not that expensive. I think they're like $20 or $30. And the nice thing about them is they're great for grabbing that crown that falls back in the back of the throat and you're trying to retrieve it. There's a little ring on the end, and we'll look at a close-up of it later on. But McGill forceps is a very nice thing to have in your emergency kit. What kind of drugs? I'll go over the drugs relatively quickly. It's in your outline in detail. Is that focused or semi-focused? Is it okay? It just looks a little blurry up here. Can someone try to focus the projector? These are the primary drugs that I think everyone needs to have in their office without question. Certainly epinephrine and Benadryl for allergic reactions, nitroglycerin for the patient that's having angina, some sort of bronchodilator inhaler for the asthmatic or allergic reaction, some form of anti-hypoglycemic agent. It can be something as simple as honey or a Snickers bar or something like that. But I would recommend you consider getting something called Instaglucose that we'll look at later on. You can buy it at Fred Meyer's. It's very cheap. We need oxygen. And the new thing this year that I think everyone needs to have in their emergency kit is aspirin. That's not for the headache you get after the emergency happens. But we'll talk a little later about why we want to put aspirin in our emergency kit. As we increase the level of care that we're providing to patients, especially in terms of sedation, or you do work on many medically compromised patients in the environment or setting that you're working, we might want to change a little bit and add some other drugs for anticonvulsant. We no longer recommend Valium, although Valium works real well. Versed is probably a better drug. Morphine for the MI patient, a vasopressor to raise blood pressure, and a variety of other things that we'll talk about as we go through the lecture today. But these are much less important. I think these are the primary things. So if you look at the list I just went over for the equipment and the drugs, it's relatively short. You don't need a big fancy kit. You can go out and buy one, but I don't think you really need to do that. One important thing, one caveat that I always put in here is, remember, it's unusual, very unusual that in a dental office setting, the medical emergencies that you're going to face, that you need a lot of drugs for. It's very rare. Mainly it's just good old basic life support the patient needs. And if you're not sure, don't give it. If you don't know what medicine they need, or if they're really having that allergic reaction and you're not sure, don't give them epinephrine. Now you give the patient epinephrine, now they start having chest pain, you give them nitroglycerin. You give them the nitroglycerin, their blood pressure falls. And you can kind of get into a cascade of events you don't want to get into. So if you don't know, don't give it. And for the staff in the room, that's why you keep an orange in your emergency card, right? Everyone know why? You give the orange the injection. If you're not sure what to give or how much to give, and you look at the doctor and he's really sweating on his forehead and his upper lip, and he's kind of shaking when he draws the drug out of the bottle, tell him to give a test dose to the orange before he gives it to the patient. And hopefully by the time he does that, the patient will be getting better anyway. So keep an orange in your emergency kit. What kind of kit you have, you need to think about what kind of practice you have, where you are. I'm 140 yards from the emergency room. I probably don't need the same drugs as someone practicing in Timbuktu or way out of town. You may need to do more in your scenario that you're in. So think about where you are and what you might need to provide. If you're using a lot of drugs, you need to make sure you have the antidotes for those drugs, the reversal agents for Versed and Valium. Narcan if you're giving a lot of narcotics, that kind of stuff. You need to have some sort of an organized box to put them in. I think a tackle box works great. We all had them in dental school, so we're kind of used to that mentality. Certainly there's a lot of commercially available kits, but these are outrageously expensive, and they may or may not have in them what you need to have for your office. So even though I bought this one years ago and now I've just totally disassembled it because I hate it, but you can certainly go out and buy these kinds of kits. And they, as far as updating your drugs, you can even pay a $29 a year fee, and they'll remind you that your epinephrine is out of date and charge you an arm and a leg to replace it. So I don't really strongly advocate those. What I really advocate is buying a multi-layered tackle box, kind of putting in it what you need in some systematic order so you can get at it and kind of develop your own. If you want to buy one, my recommendation is you buy the one that Dr. Hal Oyen has designed. How many of you know Hal? Hal is an amazing, intelligent guy and has really come up. Right now he's designing a new heart valve, honestly. I mean, he's a dentist designing heart valves, a real sharp guy. And he came up with a kit that I actually have 6 of them in my office. They work pretty well, and that's, if the medical emergency doesn't go well, at least with these you don't feel bad about it. Anyway, I have to give Hal a little bit of a hard time. It's kind of funny. Anyway, what kind of things do we need to worry about? When do they happen? Where do they happen? What kind of problems do we see? This is out of Malamed's JADA article back in 1993, and they looked at, in a private practice setting, they looked at 30,000 emergencies, and the frequency of them is listed here. If you look at these, fortunately, these things on the left side are all fairly simple to manage. Everyone in this room probably already knows how to manage them. We're going to go over them today. And I think it's something like 95% or so occur on this side of the little graph here. And there's a lot of different things that happen, but most of them are fairly simple to manage. And those are the ones we're going to kind of concentrate on today. We're going to do some of these, but not all of them. When do they happen? What stage of treatment are we at when the medical emergency occurs? Unquestionably, the most common medical emergency is syncope. Syncope usually happens when we got that little sharp stainless steel thingamabob in their mouth, giving them the injection or right after we give them the injection. So since the most common one is syncope, and it's most commonly associated with the local, immediately after or during the local anesthetics, over half of the medical emergencies occur. The caveat to take home from that is to not abandon the patient right after you inject them. I know this doesn't happen in your offices, and I know it never happens in my office, and that is you get behind. And so what you do is you tell Susie, hey, Sue, put the next patient in room 2, and I'll run in there and get them numb, well, and then I'll come back here and finish. And, I walk in and say, hi, Mrs. Jones, have a good day. Lean your head back. I'm going to get number 14 numb, and we'll be back with you in just a second to get you taken care of. And now that patient's in the room alone, and that's when they have their syncopal reaction. It might be a minute or two after I inject them. So when you inject someone, don't abandon them right away. Give them a few minutes to make sure they're okay. Not only during our treatment, but after the treatment or even after they leave their office, a lot of people have medical emergencies. So there's nothing that concerns me more than one of my staff coming up to me afterwards, after the patients walked out of the office and said, well, boy, when Mrs. Jones was leaving, she was a little shaky. You as a staff, if you see Mrs. Jones is leaving your office and she's a little shaky, tell her to come back and talk to you for a second. Have a seat. Let me get you a little cup of water. We want to make sure you feel all right before you go out and get in your car and have a syncopal episode or a heart attack and kill someone. So the staff, in here has to be pretty vigilant on the doctor's behalf. We're a team trying to treat the patient. What kind of treatment is going on? Everyone looks at those roots and says, ooh, how did he get those out in one piece? And I still try to figure that out myself. I don't really know, but those are 2 upper wisdom teeth that both came out in one piece. There's no root tips left. That is not a broken off root. That's the whole thing. And the technique is called luck more than anything. The data over here on the left side just shows what treatment is being performed, tooth being extracted or the pulp being removed, first step endo. Obviously, those are patients that are under higher stress. They're more likely to have medical emergencies because of that. It's usually kind of more emergent treatment. So when you're doing those procedures on the patient, you want to have a higher vigilance. The patients are more stressed. They're more likely to have problems. And the other caveat you take from this is what? What do you learn from these 2 things right here?
Refer out extractions.
Refer out all your extractions. That's the undertow of that slide right there. Not right there. But just be more vigilant when you're seeing the patients having those procedures done. When we have a patient that does have a medical emergency, we need to now assess the patient. And this is the time we put on our running shoes and have to act quickly. And it's very important that we do act quickly because we can spend a lot of time trying to figure out exactly what's going on. I know we all worry about the diagnosis a lot, but that's kind of the last thing we want to do. And just one quick slide. This is kind of the PADCD approach to managing patients having medical emergencies. At one time, we just kind of thought about, we got to figure out what's wrong with them and treat it. And we need to take a step back from that, as all this slide is saying, is we need to position the patient, we need to check their airway, their breathing, and their circulation. And then we need to make a diagnosis and manage it. But don't forget that airway, breathing, circulation. We get too caught up in, oh God, what did Neil say I was supposed to give this patient? I think she's having an allergic reaction. We'll evaluate the patient. Don't jump into treatment before you really assess the patient, get them positioned in the appropriate position, and we're going to go through that for all the medical emergencies we talk about today. But don't underestimate the importance of looking at basic life support for the patients that are having a medical emergency. We really need to do that. Now we're going to kind of get off into the different medical emergencies. You can divide them up a million different ways. Some ways are way too complex. I try to keep it relatively simple. And this is kind of the route we'll take as we talk about the medical emergencies today. The first thing we're going to look at is the unconscious patient. And all the pictures of the young ladies here are not my staff. I don't hire 12 and 14-year-old staff folks. These are actually, this is my youngest daughter, Melissa. And the other gal you'll see in the slides is my oldest daughter, Leslie. Isn't that right, dear? My wife's back there, so I just make sure I got them straight. But these are my two children who I am extremely proud of, so they're always in every lecture I give, in one way or another. Patients who become unconscious in our office, there's a variety of mechanisms by which they may have lost consciousness. Certainly the two most frequent ones are going to be not enough blood flow to their brain or not enough oxygen getting to their brain. Those are the ones that we normally see in our offices. There's other things, metabolic deficiencies like the insulin shock patient or the diabetic ketoacidosis or the highly uremic patient that's in bad kidney failure, seizure disorders, problems with the nervous systems, and there's a variety of psychiatric type problems. I don't know anything about them where the patient can become catatonic and at least seem to be unconscious in your office. Those we're not going to talk a lot about because, number one, fortunately they don't happen. Usually the crazy patient you recognize at the front desk and refer them out and don't have to worry about them. And there's really not too much at our level of training that we can do with those patients anyway. In our offices, in the dental environment, unquestionably syncope or fainting is going to be the most common one. Maybe the drugs that we give the patient, not so much a local anesthetic, but if you give them Ativan or some sort of medication preoperatively to sedate them, orthostatic hypotension, seizures, in the insulin-dependent diabetics, maybe hypoglycemia or CVA, someone having a stroke. That's kind of the common things that we're going to see in a dental environment anyway, causing it. And without question, vasodepressor syncope is going to be the most common one. The unconscious patient, all of them are managed the same. Remember the PABCD. Positioning, airway, breathing, circulation. We're going to do basic life support on an unconscious patient and not worry about how they got unconscious. Even in a medical center, when I was in my residency working on internal medicine, we saw codes all the time responding to unconscious, non-responsive patients. And there was times where people forgot airway, breathing, circulation. They're all, the two physicians that get there are arguing about, well, she was in renal failure, maybe it's this, and the other guy says, well, it could be a stroke, and they kind of forget that you have to breathe for the patient, open their airway, and do those important things first, and then manage the problem, diagnose and manage the problem. So we're going to recognize, Annie, are you okay? Are you awake? What's wrong? Put them supine. We want to elevate their legs. Usually, the most common reasons for unconsciousness in our office is going to be syncope, and we want to elevate their legs. That helps return blood flow back to the brain where it's deficient. That's why the patient is passed out. We position their airway. We do the look, listen, and feel, see if they're breathing. If they're not breathing on their own, we're going to breathe for them with our bag valve mask, not that mouth-to-mouth stuff that we used to learn in BLS. Hopefully, now when you take basic life support, they should be teaching you how to use the bag valve mask in your office. So the other step of basic life support, check the carotid pulse. And of course, if they don't have a carotid pulse, we're going to start CPR. During that whole process, we may or may not be calling 911 to get the emergency medical system to us. But basically, if you evaluate a patient and they're unconscious, and if you think it's just syncope, you might want to hesitate calling 911. But it's very important to get these guys on their way. These guys are on break right now, but it's very important to get them coming to you early on in management of the patient. So if you do think it's something serious, we want to call 911 early. But only after we do airway, breathing, circulation do we worry about why the patient is unconscious. That's very important to remember. Dear, she wasn't drinking, honestly. It was vasodepressor syncope, just simple fainting. Unquestionably the most common problem we see in our offices, and probably if I ask people to raise their hand, everyone's had someone in their office faint. I've had 2 staff faint in my office. Syncope is a relatively common problem in everyday life, and when we're under stress, we tend to do it a little bit more, especially when the slide won't go. A variety of predisposing factors. I mean, I think we're all very familiar with this information as far as unwelcome news or a real stressful event occurs or they see blood, something like that, that scares the patient. Upright position, the soldier standing at attention for too long, the hypoglycemic patient that hasn't eaten. The one thing you want to keep in mind is who faints. You know, it's the macho surgeon who thinks he can do anything. That's not me. That is not me. The macho surgeon thinks he can do everything. He comes in, he's real stoic. You know, you get ready to inject him, and he's the guy that passes out. But it's usually the patient in their late teens up to maybe 35 years old, and it's always the macho males. I cannot remember the last time a female passed out in my office, but I have the advantage when I sedate patients, take out their wisdom teeth, I have them hooked up to monitors. And I can see the patients that would pass out if they were more upright and weren't supine already. And I see it in males all the time. Their blood pressure falls, their pulse rate falls. I see it all the time in males. Very rarely do we see that in females. But the age group, the only reason why I emphasize this is if you have a 6-year-old kid who you inject in your office and they become unconscious, or you have a 70-year-old man in your chair and you inject them and they become unconscious, syncope shouldn't be your #1 differential diagnosis for their problem. It's the macho male in this age range that faints. An old guy probably had cardiac arrest or some sort of cardiac arrhythmia. The young kid may have had some sort of anaphylactic reaction or something. There is anaphylaxis, that they have no signs or symptoms of allergy. They just have complete cardiovascular collapse immediately. So when you think about, I injected the 80-year-old guy or 60-year-old guy and became unconscious, you certainly want to consider syncope, but put it down the list, because those aren't the type that faint. The 70-year-old guy, I'm taking out 18 teeth and I tell him, it's a lot of teeth, we're going to give you dentures, 18 teeth, we ought to maybe sedate you or put you to sleep. Oh, just get me numb, no big deal. They can take anything, but these guys can't. They're a bunch of wimps. They are. I hate taking out wisdom teeth on an 18-year-old studly guy. I mean, number one, my staff never pays attention to suction. Anyway, why do we faint? We see something that scares us, or we have pain or fear. You all know what this is, right? Have you seen the latest O? The O journal? This is my article on dry sockets. And this is an electron microscopic picture. It is, honestly, of the bug that causes dry sockets. And so when the patient comes in, my patient, I have 2 dry sockets a year, by the way. And both of them, when they come and they say, why does this hurt so bad? I hold this picture up and say, that's the bug that's causing it. And so they can understand. I'm just trying to keep you awake. Pain or fear, our body releases an amazing amount of adrenaline. And it's called a flight or fight response. The lion comes at us, we release epinephrine. What that does is our body shunts the blood from our stomach, because who needs to digest food if you're going to be killed? It shunts the blood out to your arms and legs, so you can either fight the lion or run away from the lion. And when you start to run or fight, your muscles contract, and it sends all the blood back to your heart so it can keep pumping it around our body and keep us functioning and fighting. That's a normal physiologic response to fear. And cardiac output is maintained and you don't pass out. We come to the dental office and they come at us with this great needle that we're scared of, we're uptight, we're tense. So we have pain and fear. The catecholamines are released, the epinephrine is released. That pumps the blood up to our arms and legs, and the normal response to that, the normal physiologic response is to either fight or run. And so the patient, what do? They start kind of, moving around in the chair, and what do? No, just hold still for a minute, I'll be done in a second, hold still. And so we kind of interrupt that normal cycle of pumping the blood back to the heart. So The blood pools out in the muscles of our arms and legs, and our brain says, hey, no blood's coming back to us. We better kind of close down the arteries and veins in our systems. We have vasoconstriction. We speed up our heart rate, and that compensates for that blood being pooled out there. But very quickly, the compensatory mechanism fatigues, kind of shuts down. Our brain tells our heart, slow down, something's amiss. And the problem is there's no blood coming back to the heart rate falls, and so there's no blood coming out of the heart going to our brain, and we pass out. So we interrupt the normal physiologic fight or flight response. What do the patients feel? I think everyone is familiar with patients fainting because we've all had it. You know, the patient feels warm and flushed or tingly. You know, a lot of them will even tell you, I think I'm going to faint, or I feel faint, or I feel nauseated. That's very common when you have cerebral hypoxia. Nausea is a common problem. Early on, their heart rate speeds up. They have a little bit of tachycardia again. To try to, the brain's telling the heart, hey, pump more blood, pump more blood. But like I said, very quickly, later on, it's going to slow back down and they'll have bradycardia or a slow heart rate. And the bottom line is eventually we have cerebral ischemia, not enough blood, not enough oxygen going to the brain, and we actually become unconscious. And I think, again, everyone's kind of familiar with this because we've all seen patients, you know, a little bit sweaty on their forehead and kind of cold and clammy, no color. They look pale as heck. So what do we do? Very simple to manage. You know, the number one thing, the reason why if I fainted right now, God is very smart. If I fainted, what I would do is I would become horizontal very rapidly. And that's the main thing we need to do to treat the syncope patient. Not long ago, I was actually disappointed in one of my very best assistants, kind of panicked because the patient became syncopal and we hadn't even started treating him, was lightheaded. She said, all his color's out of his face, you know, you need to come and look at him. And when I walked into the other room to look at him, he's almost upright in the chair. You know, before you even go and run and get the doctor or run and get assistance in the office, you need to put the patient supine. That's, you know, how we treat the patient. And usually you won't even need the doctor because by the time you get back in the room, they'll be fine. So assess their level of consciousness. They may or may not go out completely, obviously. We're going to put them supine. We want their feet above their brain. That puts about another liter of blood back into the central circulation very rapidly. And you can even lift them up. I mean, in patients having a real bad syncopal episode, just have one of the assistants grab their feet and actually, you know, lift them up, and it drains the blood out of their legs back into the central circulation. Assess airway, breathing, circulation, just like we do in every unconscious patient. And once we put you into the supine position, if you were just having syncope, remember the differential diagnosis for the unconscious patient in this setting is they have a acute anaphylactic episode without any signs or symptoms of allergy. They have acute cardiac arrest, sudden cardiac death from an arrhythmia. They could have just had a massive stroke because they were bearing down when you were injecting them. They had a massive intracerebral bleed and became unconscious. So there's a lot of other things that could have caused this. We all tend to think, oh, the patient just fainted, no big deal. But how we know that they fainted is how quickly they recover. When you take a patient that's had a syncopal episode and put them horizontal, you know, supine, elevate their legs, within 10, 15, maybe 20 seconds, they should be responding to that treatment. Now, that doesn't necessarily mean they'll be able to tell you their address in 20 seconds, but if you put the patient into that position, they should be able to you know, start moving around or, you know, opening their eyes or, oh, what happened, or, you know, some sort of response in a very short period of time. If you go 20 seconds and that patient isn't responding to being put supine, call 911 because there's a good chance that something else is going on other than just simple syncope. Certainly we're going to give them oxygen, monitor their vital signs. Again, remember, airway, breathing, circulation. Evaluate the patient for that. Don't forget that. Definitive things we can do, I mean, we all know, like the smelling salts, a cold towel, you know, you stimulate the patient, you know, Melissa, are you okay? You know, pinch their trapezius muscle, whatever you want to do. And again, they should be responding to that very rapidly. The patient that does go into a full syncopal episode, in other words, they become unresponsive or unconscious, not just, I feel lightheaded, you lay them back and they feel better. I would consider that a near syncopal episode. But someone that has true syncope, you might want to consider not treating them that day. Especially if you're doing something real involved. I mean, if you're doing the DO on 12 and it's going to take you 10 minutes or whatever it takes, that's probably fine and the patient feels okay once they recover. But if you're doing something pretty extensive, you might want to reconsider treating the patient that day, postpone them for the 2.5-hour crown and bridge monstrosity procedure that you're going to do, and consider sedating them before you do it the next time. Just with PO sedation type stuff. These patients that have a true syncopal episode, you want to be careful. If they become completely unconscious, you want to be careful sending them home by themselves. Because patients that have a full-blown syncopal episode for even up to 24 hours, but certainly in the immediate couple hours after their episode, they are very prone to having a resyncopal attack. So you say, Mrs. Jones, you passed out when I gave you your shot, and it took you a couple seconds to come around, and it took you 5 or 6 minutes to really kind of clear your head, and I don't feel comfortable going on because you're really anxious, and I think we need to reschedule you. Don't say, bye, have a good day, have her get out in her car, driving down I-5 and go, oh, that was a terrible appointment, and pass out in her car and kill someone. So at least consider whether or not the patient needs to be escorted home or have them sit out in your waiting room for half an hour, 45 minutes to make sure that they are fully recovered. You want to check their vital signs before you leave their office from a medical legal standpoint. You want to check their vital signs and document that in your chart. If you have a patient that has syncope and it takes them a while to recover, in other words, they wake up, but every time you try to sit them up, they get lightheaded, or they just, 10, 15 minutes goes by and they still feel kind of weak and lousy, you might want to consider shipping them off to the emergency room by calling 911. In those instances, when you call 911, let them know what's going on. I mean, call 911 and say, hey, I have a patient who passed out, and just as they're getting better. And that way, when the ambulance comes, they don't come red light, siren, and scare all your other patients in the waiting room and everyone around you. I mean, they just drive to your office, pick up the patient, and take them away. 911 doesn't have to be red lights and siren. If you tell them it's cardiac arrest, it will be. But this, you just need ambulance transport. And you don't call A1 ambulance, you just call 911. It's much easier. But those patients, delayed recovery should be considered something you want to send to the hospital, or at least call their physician and talk to their physician, because it may be some cardiac etiology. They're going in and out of ventricular tachycardia, and that's why they're becoming syncopal. It may not just be simple syncope. How do we prevent it? We need to give more drugs. I said that earlier. Drugs are good. Nervous patients are bad. They have more medical problems, medical emergencies in your office, and you have a more stressful day. So we need to give them more drugs. The syncopal patient, if you put them supine before you inject them or work on them, they're very unlikely to have syncope. But the big thing is anxiety relief, preoperative sedation, or using nitrous oxide on them. If you use those two in combination, remember you have to have a different level of permit, right? I mean, read the Oregon Board of Administrative things. If you use those two in combination, you have to have the sedation permit, not just the nitrous permit. One drug that I will leave you with that many of you probably have never prescribed or used is Ativan. When you have the nervous Nelly patient that's coming into your office, a lot of you use Valium. Valium is a good drug, but it's been around a long time, and there's newer, better benzodiazepines that I think cause less emotion. There's nothing more problematic than giving a patient that's nervous Valium. It causes so much disinhibition that they're teary-eyed and crying when they come to your office. If you use Ativan or lorazepam, it's a little longer acting benzodiazepine. It is very smooth. The patients who you give it to, I use it a lot on patients that are nervous. They absolutely are stunned at how calm they are. It comes in 3 different tests, 0.5 milligram, 1 milligram, 2 milligram. If I'm working on an old patient, in their 60s or 70s, I'll give them 1 milligram. But a normal adult that weighs over 100 pounds, I give them 2 milligrams of Ativan to be taken 1 hour before their appointment. And they come in and they say, Dr. B, this is great. Pull my tooth, no big deal, and you're good looking. I mean, there's some secondary benefits there. But Ativan, just keep that in the back of your mind. Get rid of Valium. Valium's not a terrible drug, and if the patients have taken Valium before and done well with it, use Ativan. Under 100 pounds, I usually give 1 milligram. Over 100 pounds, I give 2. Obviously, if the 150-pound person says, oh, I'm real sensitive to drugs, I might only give them 1. And then to kids, and I'm talking about kids that are 6 to 10 years old, not 2-year-olds, I give them 0.5 milligram of Ativan. And it's amazing how nicely it works. Very good drug to have in your armamentarium. The next thing we'll talk about, and then I think he needs to take a break there for his camera. Does a blinking light mean anything? Okay. Postural hypertension is the next thing we'll talk about, and everyone recognizes that. The patient's happy as heck to have the tooth out. They got the gauze in there, and man, they are headed for that door. We see it all the time. They jump up out of the chair a little bit quicker than they should and end up on the floor. And it's nothing more than a kind of a inadequate response to positioning of the patient. Right now, as I stand before you, the veins and arteries in my legs, my brain is telling them to constrict so that it keeps the blood up here into the brain area. There's a mechanism that kind of keeps you normal blood pressure in your squash when you're standing up by constricting your legs. If we put someone in a supine position, especially for a prolonged period of time, the system kind of gets lazy, shuts down, and doesn't work very well. And when we go to sit you up, the blood pressure in your brain falls dramatically. And some people are much more prone to that than others. There's actually inadequate postural reflex, which is Shy-Drager syndrome. There's actually, patients, I'm holding my fingers up there, actually patients who have a real problem with that reflex. The biggest thing is drug administration that I see. What percentage of your patients take these different drugs? The antihypertensives. If you took antihypertensives and the tranquilizers or antidepressants, I would say every patient I see is on those. And they make you much more prone to postural hypertension. And a variety of diseases, Addison's disease and pregnancy also make you more prone. So in your medical history, you just need to be aware of these things that your patient may be taking or be affected by, makes them more prone to that. There's actually criteria. I don't think this is important to know the criteria of who has postural hypertension and who doesn't. That's to make the medical diagnosis. The bottom line is if you take the patient from a supine position to an upright position and they become lightheaded or a little bit weak in the knees type thing, that's how I would diagnose postural hypertension. Don't worry too much about this, taking their blood pressure and knowing exactly. We treat it basically just like we do syncope. We put them in a supine position, we elevate their feet, we're going to check airway, breathing, circulation, maybe give them a little bit of oxygen. If they're getting syncopal-like, you might use an ammonia inhalant and stuff. But usually just putting them back supine will be adequate, and the episodes usually terminate very quickly and really aren't a problem. Postural hypertension shouldn't be a problem. Just like with syncope, if every time you sit the patient back up, they get lightheaded, maybe it isn't just postural hypertension. I've had one patient we ended up sending to the emergency room that the problem was he actually had a cardiac arrhythmia that it was affecting his cardiac output, and every time we set him up, he got lightheaded again. After about 30 minutes, we called the ambulance to take him to the hospital, and ended up he was there 2 or 3 days getting some sort of cardiac problem managed. So if it doesn't respond quickly, you want to get someone there to help you. To avoid it, know what medications the patient's on. If they have a real strong history of fainting, they're going to be more prone to it. Again, we're going to check the blood pressure. Patients that are hypotensive at the beginning of the appointment will be more prone to this. And the big thing is, we all know, is slowly discharging from the supine to the upright position. I know, my chair has a little button you can hit, and it's the auto, I call it the auto eject button, it just sets them straight up. Fortunately, I think some of the dental chairs they make today, when you hit that button, it takes them part way up, and then you have to hit it again to make it go all the way up, right? Maybe, maybe not. I've seen some that do that. But sit them up slowly, especially the old patient. I'm getting the sign. Go ahead. Mainly kind of talk about the result of adrenal insufficiency rather than the pathogenesis behind adrenal insufficiency, because that's a 2-hour lecture all its own, and we don't have 2 hours to do that. But certainly, the number of patients that we see on exogenously administered corticosteroids today is extremely high. The number of autoimmune disorders that are treated today with prednisone or other steroids, mainly prednisone, is very high. What does this patient have? Lupus, SLE, systemic lupus erythematosus, has a typical butterfly rash across the center of their face. Typical SLE patient will be on long-term steroids. And there are a numerous number of people that take long-term steroids. This is probably a little bit hard for you to see. It's in your handout, and it's not super critical. I just want to make a point that in a normal gland, normal adrenal gland, when we're under stress, in order for our body to handle the stress, and I'm talking about significant stress, not minor little everyday stressful things, but if we put a patient under significant stress by doing the 12-hour crown and bridge prep on them, they have a mechanism whereby their hypothalamus and their pituitary and adrenal gland actually put out more steroids. That's the bottom line, is we need steroids for our body to function well under stress. And so there's the HPA, hypothalamic, pituitary adrenal axis, puts out more steroids. If we have a hypofunctioning gland, the adrenal gland won't work properly, like in a patient with Addison's disease. We have a problem in that everything in the system works properly until you get down to the adrenal gland, and it can't put out enough corticosteroids. And so you have acute adrenal insufficiency. We don't see this very often. Addison's disease is not a really very common disorder. On the other side over here is we have exogenously administered steroids, the prednisone that we give the patient that has SLE or asthma or a myriad rheumatoid arthritis, a myriad of other autoimmune disorders. And in those, what happens is we administer the cortisol or the cortisone to the patient, the prednisone basically, and it tells the entire system that, hey, you don't need to work very hard. The pituitary doesn't need to work. You don't need to put out a lot of ACTH. The adrenal gland doesn't need to put much out because there's plenty around. Not a big deal. The problem is over time the adrenal gland atrophies. Just like we do. If we don't exercise every day, we atrophy. I seem to be getting bigger, but the atrophy thing works in there somewhere. But if the adrenal gland atrophies a lot, it becomes hypofunctional. The problem with that is when they do have stress, or they take the steroid away from us, they quit taking it, when we do need the adrenal gland to put out a lot of steroid, it no longer has the ability to do that. It's atrophied, it's just not as efficient at making the cortisol. And those are the patients we get in trouble with mainly is people that have been on long-term steroid therapy and suddenly, for whatever reason, 2 weeks ago quit taking it. So when you have them fill out your medical history, they don't even list it, right? Because it's not a drug they're taking. Yet 2 weeks ago they were taken off of it. The problem with those patients, again, is we stress them. In order for your body to maintain normal hemostasis, you need a certain level of the cortisol in your system. The bottom line is cortisol makes it primarily so that your blood vessels respond to epinephrine and norepinephrine appropriately to maintain your blood pressure. If you have inadequate steroids in your system, cortisol specifically, epinephrine won't increase your blood pressure, and you become hypotensive and unconscious. How suppressed the HPA axis system is depends on a variety of factors. And again, we're not here to talk about them because it's a little bit complex. What time of day they take it, is it oral or parenteral, how frequent, what the duration is, and of course what the dose is. Obviously, higher dose steroid suppresses the adrenal gland more than low dose steroids do. But this is a little bit too complex. So what we came up with in dentistry and in medicine to some extent is the rule of twos. I don't particularly like the rule of twos because it's a little bit too simplistic in many of the complex cases that I see. But for in everyday dentistry and the kind of stress you put the patient under, which is not quite what I do, I think that the rule of twos works well. And that is that suspect that the adrenal axis is suppressed if in the last 2 years, for a period of at least 2 weeks, the patient has taken a dose of steroids greater than or equal to 20 milligrams of cortisol on a daily basis. And that's about the same as 5 milligrams of prednisone. A lot of times they administer prednisone, like in rheumatoid arthritis, they'll give them 5 milligrams every other day. The reason why they give it every other day is it gives a day for the adrenal axis to kind of recover, and you don't have as much adrenal suppression. But if for 2 weeks in the last 2 years, they've had more than 20 milligrams of cortisol equivalent, consider that their adrenal gland cannot put out enough cortisol during times of increased stress. And so in those patients, you may have them in, Dr. Strong may have them in to do the periodontal procedure. They're a real nervous patient, and that is a very stressful event for the patient. The physicians don't quite understand how stressful having dentistry is on normal patients. Most physicians are pretty good in the office. They don't think it's that big of a deal. But if you have the nervous Nellie come in and has an hour and a half periodontal procedure, oral surgery procedure, I'm not picking on Dr. Strong, it definitely is a stressful event for them. And they can undergo or have an acute adrenal crisis. What we usually see in those patients is they become very weak. They may feel tired even before they get there because it's already kind of started. It isn't something that just happens in your office. Nausea is a big component. Hypertension is probably the biggest thing. Their blood pressure tends to bottom out. Even though they're nervous, and you would think that if you're nervous, your blood pressure would be going up, they usually become fairly hypertensive. And I've seen this one time, by the way, so you're not going to see it a lot. Mental confusion. The guy that I saw that had it came in with a massive infection. I was going to do an IND. He was already into acute adrenal crisis when he walked into the office. And the more I talked to him, the more I realized how confused he was about what was going on. And a normal patient, other than the fact that he was on long-term high-dose steroids. And this is a patient just with erythema multiforme, another thing that we frequently see the patients on long-term steroids for. So what do we do when the conscious patient? Position them comfortably. They don't necessarily need to be supine. Unless they're symptomatic, they're lightheaded, or their blood pressure is low, then you'd want to put them supine. Again, check airway, breathing, circulation. And I keep harping on that. And keep in mind that if the patient can talk to you and respond appropriately to your questions, their airway, breathing, and circulation is probably just fine. But if they're compromised mentally or don't seem to be responding appropriately, we need to really carefully address those. Monitor vital signs. Certainly this is a potentially life-threatening problem, so early on we want to call 911 and get them on the way. And what we want to administer to them is steroids. You can never give a patient that may be having an adrenal crisis too much steroid. There is no such thing. Too much steroid in the short term has very little ill side effects. Long-term high-dose steroids is not good for us, but short-term is not a big deal. We always use Solu-Cortef, hydrocortisone, sodium succinate. The reason is it's immediately available to your body to use. You can't use Decadron for these patients. Decadron takes up to 6 hours to really be effective. So we use Solu-Cortef as a drug of choice. We give it to them either IM or IV would be the preferred route. We give them 100 milligrams, and then we usually start them on a Solu-Cortef drip I mean, this is the dose that's going to save their life, is the initial dose you give them. And then we usually put 100 milligrams in a liter of saline, because most of them are hypertensive, and run that into them as well. And this is what the EMS people, if you don't have it in your office, and probably most of you don't, this is what the EMS people will do when they get to your office. They'll put an IV in the patient if they suspect this and give them solute Cortef. Unconscious patients, basically we're going to manage the same, other than we need to provide airway breathing circulation support to them for sure. Okay, again, solute Cortef, 100 milligrams IV or IM is a life-saving maneuver. And this is definitely a death-inducing problem. I mean, they actually will die in the chair. Let's go ahead and take a break. Any questions? At the end of today, I will be glad to stay and answer all the questions you have. Don't worry about that. If you have specific cases you want to ask about or something, I would be glad to do that with you. Respiratory emergencies is the next thing we're going to talk about. Keep in mind that when your patient has respiratory distress, they're not getting enough air, or they feel like they can't breathe, it always isn't their lungs that are causing the problem. There's a variety of disorders that manifest as respiratory distress that are listed up here on the slide. You know, we have an MI, obviously asthma, the kind of typical things we worry about, but someone in congestive heart failure, but a variety of different disorders cause respiratory distress. Today we're mainly going to kind of focus on the true respiratory type of things that go on. Airway obstruction, I think they teach pretty well in basic life support. Not something that I actually think we see too often in our offices. That we're not giving our patients hot dogs. They might swallow or aspirate a crown, but that usually doesn't cause complete airway obstruction, although I suppose it could. The partial airway obstruction patient, has a weak ability to cough. I mean, if a patient's having trouble breathing, regardless of whether or not you think they've aspirated something, ask them to cough. If they have a really weak cough, that usually means that there's some sort of compromise of the airway system itself. And just a good evidence that they're having partial airway obstruction. Patients that have a crowing sound when they inspire, we call that stridor. And it's usually related to laryngeal edema from like an allergic phenomenon. You want to think about that. It could be from a crown sitting on the vocal cords causing to contract just a little bit, but think about laryngeal edema. And obviously if they have complete airway obstruction, they can't get any air exchange, they can't cough, and most importantly, they can't speak. So if you have a patient that's talking to you, they just have a partial airway obstruction, and you certainly don't need to respond to them quite as urgently in their management. I don't want to spend a lot of time on this. Again, basic life support teaches you, the patient becomes unconscious, put them supine, do the finger sweep, try to ventilate them twice. If you can't get air in, we do 6 to 10 abdominal thrusts, and then redo the finger sweep, and just keep doing that cycle until you get the airway open. We don't do back blows anymore. That's really ineffective, especially in adults. We still do it in infants, but in adults we don't turn them over anymore. Just do abdominal thrust. The one thing about airway obstruction I do want to mention today is that little crown that somehow gets a little bit of spit on it, and it's amazing how slick it is once it gets spit. Rubber, gold, and spit were never meant to be next to each other. And now we all wear gloves, and it's amazing how slick a tooth can be with a little bit of spit on it when we're trying to grab it with a pair of gloves. And so we're going to talk about that lost crown or the lost tooth that kind of disappeared. You thought number one was going to be hard to extract, and you cranked on it just a little bit, and it popped out of the socket and went in the back of the throat, and the patient goes, and all of a sudden you can't see it anymore. And the question becomes, where did it go? There's only two places it could go. One of them is good, and one of them is really bad. And if they aspirate it into their lung, we all think that, the patient's going to be coughing or wheezing, or they're going to have airway obstruction, inability to speak, or inability to breathe very well. But keep in mind that most patients do have those symptoms within the first hour. 90% of the patients will have symptoms of airway compromise within the first hour. Heck, that means for the first 20 minutes, they may be perfectly comfortable. Maybe a little bit irritating, but not too bad. 10% of the patients, it may be 6 hours before they have any pulmonary or respiratory distress from the crown. So if you have the crown or tooth go back in the back of the throat, you have to know where it went. You can't take the patient's word, I think I swallowed it. That doesn't mean anything at all from a medical legal standpoint primarily. Certainly a swallowed object, they're going to be completely asymptomatic until your sharp crown margins pass in the wrong spot. And this is where the McGill's forceps, this is a McGill's, M-A-G-I-L-L-S. They're just basically a bayonet-shaped pair of forceps with little rings on the end. There's nothing worse, and you've all done it because I know, I did it, I practiced general dentistry for 5 years, and you drop something back in the back of the throat, and what do you try to pick it up with? Something that was meant to pick up cotton. That's why they call it a cotton forceps. It's for 2x2s and cotton pellets. And what are those little tongue roll things, those little sponge things? It's not to pick up crowns out of the back of the throat because sure as heck, as you grab it, it propels it further down. And so these are nice to have just at your, in your DTR or readily available because the little ring at the end, you can grab almost anything with. A crown that goes back there that you knock off or falls out of your hand when you're trying to seat it, or a tooth. They work very well, and they're not very expensive at all. So the patient maybe aspirated the crown. We're not sure. It went down into the throat and disappeared. The patient's absolutely positive he swallowed it, but you need to manage the patient differently. If it disappears, what you want to do is leave the chair supine. Don't sit the patient upright. If it went into their airway, what they want to do is they want to sit up. Don't let them do that. You want to leave them supine. You want them to roll over on their left side and even maybe turn, kind of hang their head off the side of the chair and get them to cough. And that, if it gets down into their lung, that will help it come out. If you sit them upright and it's in their trachea, now it will go down into the right mainstem bronchus and even be harder to get out of it. So don't sit the patient upright. They're going to be fighting to get up. And you need to tell them just lay down, turn on your left side, and cough into the trash can here or whatever. Try to cough it up. If the object is coughed up and it definitely was in the lung, keep in mind that there may have been some sort of damage to the lung. Post-aspiration complications are a possibility. And you might want to consult with either a pulmonologist or normally I would probably just call the patient's physician. And 99.9% of the time, they're going to tell you not to worry about it. Just tell the patient if they do have any, prolonged coughing or cough up blood or anything like that to get in touch with me. If it doesn't come out, do not assume it's in the stomach. Medical legally, that is a disaster. You send the patient home and they start having problems at home and, get some bad pulmonary thing going on and die, you are just hanging out in the breeze. You want to take those patients, you didn't get the crown back out, even if you think it's in the stomach, they need to go to the emergency room, either by automobile, not their automobile driving themselves, but if the ER, like in my case, it's 140 yards away, I'd pop them in my car maybe and drive them over there, or my office manager drive them over there while I, sit in the corner and trade. But, you need to get them in the emergency room, and they need x-rays done to prove where that crown is. You don't need to memorize this at all. You don't need to memorize what x-rays need to be taken. You pick up the phone, you call the ER doc and say, hey, listen, the stupid patient decided to aspirate a crown. Can't believe they did that in my office. And I need to just make sure it's not in their lung. I'm pretty sure they swallowed it. And they will order the appropriate films. We do a PA and lateral chest x-ray and a flat plate of the abdomen, which is what this picture is. This is the spinal cord you see here. This is the edge of the diaphragm you see up here. So this is, the belly, this is the intestine with the gas and stuff in it. And right there you see a very nicely swallowed, obviously, because it's below the diaphragm, 3-unit bridge. It's a lower anterior 3-unit bridge. So that's good. That's what you want to see. Because this, all things shall pass in the end, and eventually you'll be able to re-cement that bridge. You got to have a real understanding patient. Talk about how good your sterilizer is and all those things. So again, if the crown disappears, verify where it was. Don't get into a worrying match about who's going to pay for the x-rays. I mean, it's submitted to the patient's medical insurance. If you want to offer to the patient that if any part of it isn't covered by your medical insurance, be sure and send me the bill. Pay it out of your pocket or turn it over to your malpractice insurance. Your liability insurance company will pay that money. They would much rather you send them over and them absorb that cost rather than you send them home and have a $2 million lawsuit when the patient dies. So send them over to the emergency room. Another kind of respiratory emergency, or as it definitely presents as one, is hyperventilation. And this goes on in our office much more than we realize. We just don't always recognize it in the patient because it doesn't become symptomatic enough. But as you know, it goes on all the time. In my office, it's usually payday when I don't get the paychecks out as quickly as I should. The staff tends to hyperventilate a little bit. Dentistry is a high anxiety profession, both to us in many ways, but especially to the patients. This is probably a little bit small. This was in the Oregonian, little incision that runs down his neck and down onto his chest. And if you can't read it, it says, that wisdom tooth on the right side was giving me a tough time, so I had to get it from a different angle. And that's kind of the mentality patients definitely have about having their wisdom teeth out. It's a horrendous, horrendous procedure. This is what happens when we hyperventilate. When we're real anxious, we tend to increase our respiratory rate quite a bit, and that blows off the carbon dioxide in our system. And our bodies really need a certain level of carbon dioxide for normal hemostasis to occur. So if we hyperventilate, breathe too rapidly, we're going to blow off a lot of CO2. It actually has a couple different things, causes respiratory alkalosis, which causes all the calcium in our blood to go intracellular, and that causes a lot of neurological problems in terms of how our nerves work. So we have tetany of our muscles and we have paresthesias. It causes our vessels in our brain to shrink. If your CO2 is real low, all the blood vessels in your brain shrink, and you may actually develop ischemia and become lightheaded. And also, we have an increased sympathetic tone. We have a lot of catecholamines, epinephrine, norepinephrine release, and they cause a variety of symptoms like anxiety and tachycardia in the patient. So when we do have a patient that's hyperventilating, we see a variety of things. The biggest thing is air hunger. The patient feels very short of breath, even though they're breathing 35 times a minute. They say, I can't get enough oxygen in. They're short of breath, even though they're panting almost like a dog does. The fact that they release a lot of epinephrine will give them a rapid heart rate and sometimes a little bit of an irregular heartbeat or palpitations. Because of the cerebral vasoconstriction, they feel lightheaded. A very common thing is, again, the calcium goes intracellular, and they will have a little bit of carpal spasm. Their hands will kind of tighten up in their upper arms. They might even have a little bit of what looks like seizure activity. Not seizure activity, but kind of carpal spasm just a little bit, both in their legs and in their arms. And of course, they're very anxious. I mean, that's kind of a normal thing in a hyperventilating patient. So fortunately, hyperventilation is very easy to manage. It's a very minor problem. It can become life-threatening. This is the one medical emergency that if you slap 100% oxygen on them, you can actually make it more detrimental to the patient and cause them to have more problems. We're just going to position the patient comfortably. They usually want to sit upright. check their airway, breathing, circulation. If they're complaining about how short of breath they are, their airway, breathing, and circulation are just fine. You might need to remove the rubber dam. The biggest thing you need to do is calm the patient down. Normally, if you just tell them to slow down your breathing, hold your breath for a second, just relax for a second, you can get them to come back out of this. It'll let their CO2 build back up. If it's real bad, we can have them do the old thing. You breathe in a bag, tell them to breathe out, breathe in, breathe out, breathe in the bag. Let them hold it over their face, and that builds your CO2 back up and kind of corrects it. Theoretically, if they continue having problems, we'll give them Versed or Valium, mainly to calm them back down. It has nothing to do with their respiratory function. It just, if you get rid of the anxiety and calm them down, they'll be fine. And obviously, go ahead and treat them. I mean, there's nothing, unless they start hyperventilating again, it's not really detrimental to them, and let them go home. As far as letting them breathe in the bag, let them hold the bag. If you try to do it like Melissa, all that, if you're having trouble breathing, and I slap a bag over your face, you're definitely not going to like that. And this technique, the girls liked it, but it's definitely not the technique you want to be using. So hyperventilation, very common in our offices. Asthma, something that is increasing in frequency, amazingly so. I see a lot of asthmatics in the late teen population that we take wisdom teeth out on. It's just phenomenal how many people have asthma. There's a variety of things that will precipitate asthma that in a normal patient causing no problems, but in patients that have a hyperreactive bronchial tree or increased bronchial reactivity, they have an abnormal response to that. The thing that normally occurs is they have smooth muscle constriction, the bronchioles will close down a little bit, they'll have bronchial wall edema and mucus hypersecretion, which will close down their airway significantly, and they have a very difficult time breathing in and out, especially expiring is much harder usually than breathing in. And we have the classic wheezing, shortness of breath, and in many patients all they really do is cough. They don't necessarily wheeze. When we look at asthmatics, there's the intrinsic asthmatics and the extrinsic, kind of the two main classifications, but there's a lot of people that actually show kind of both components of asthma. And they're a little bit different in what we need to worry about. It's kind of funny because a lot of the intrinsic asthmatics that are exercise-induced, when I say, what causes your asthma? Oh, I don't think I have a problem with it because I only get it when I exercise. Well, the extrinsic asthmatics are the ones we normally think about with asthma. They have allergies, cat dander or food or whatever sets off their asthma. And that type of asthmatic is IgE mediated. It's a typical type 1 hypersensitivity response. And they're easy to treat. When they have their asthma attack, they're no big deal usually. We can give a bronchodilator and it reverses it very quickly. The asthmatic that is an intrinsic asthmatic that mainly they're exercise-induced or only after they have a cold or something, what they say when they come to my office is, I say, well, your asthma's a little bit of a risk when we put you to sleep. Oh, well, I only get it when I exercise. The problem with these patients is it's not IgE mediated. Their skin tests usually are negative, so it's definitely not a type 1 hypersensitivity reaction. It's not well understood what causes it. But when they have their asthma attacks, they die. The asthmatics that we've lost 2 in Oregon in the last couple of years, 2 teenagers out on the track running or some sort of physical activity, and they both died because they had intrinsic asthmatics. So these patients we need to worry about much more than the typical, in the spring when my allergies are bad, my asthma's bad. Uh-oh. We'd be on to the next step. That's the last slide on the carousel, not the first slide. Asthmatics, they may feel congestion in their chest, they may wheeze. When my asthma acts up, I've used my inhaler about 6 times this morning because I have real bad coughing attacks, especially when I talk a lot. So some patients will just have these coughing fits. They get real anxious when they're short of breath. Their respiratory rate will go up. Because of their anxiety, a lot of times they get tachycardic. Usually they will want to sit up. An asthmatic have an asthma attack, don't ask them to lay supine. They won't like that. They want to sit up for sure. In order to treat asthma, fortunately, asthmatics today respond extremely well to the variety of bronchodilators that are available. Certainly the rescue drug that we use most is albuterol, a very good beta agonist that will open the airways back up. It's very effective. So the patient having an asthma attack in your office, which will be relatively rare, will want to sit upright, check airway, breathing, circulation. If they're sitting there talking to you and breathing, they're okay. And we're going to have them take a couple puffs off of their bronchodilator. If the episode quits, goes away, which normally it will within a few minutes, you can go ahead and treat the patient. That's not a problem. If the episode continues, you can either have another hit off of their bronchodilator, or you could consider giving them epinephrine. And that's kind of the next step in treatment. If the bronchodilator itself doesn't work, number one, I would call, in your situation, I would call 911, because they may go on to have a life-threatening asthma attack. And also, going to give them oxygen, obviously. I mean, it's always a good thing. And then we're going to administer epinephrine, 0.3 milligrams, a relatively low dose, and we give it to them either IM, or probably better would be subcutaneously. And everyone here knows how to give epinephrine sub-Q, you've just never done it. It's very simple to do. We use the 1 to 1,000 epinephrine. You draw, about a third of a cc. You tighten up the skin of the arm. You take the syringe and just punch it through the skin tangentially. It's very easy to do. You'll feel yourself go through the skin, the resistance, and then it kind of goes through, and then just inject. It's very simple. There's nothing there you can hurt. Usually I will rub the area to kind of spread the epinephrine out and get it to absorb a little bit more rapidly. So in a severe asthma attack that doesn't abate with the bronchodilator, you can use epinephrine. What I actually do to every asthmatic in my office is, if you have asthma on a regular basis and your asthma's been bothering you in the last few days, is I tell you, get your inhaler out and take a couple puffs before we start working on you. It's a lot easier to prevent it than it is to treat it. And that's what the physicians tell the patients with exercise-induced asthma. Go ahead and exercise, you just need to use your inhaler before you do it. So it's a very good prophylactic medication to use on the patient. The next thing we're going to talk about is a variety of disorders that cause altered level of consciousness. This is one of my running mates in my oral surgery residency. We're out in the middle of the Pacific Ocean fishing for salmon, and Tony never left that position. He's actually a good-looking guy. He usually doesn't look that kind of green and pale, but Tony in the ocean did not get along. He definitely had an altered level of consciousness. His little scopolamine patch didn't help him much. There's a variety of things we're going to talk about and go through relatively quickly, because fortunately most of them are pretty simple, that cause an altered level of consciousness. Diabetic emergencies, lack of glucose, eating the light ice cream rather than regular ice cream like I like, is what gets most insulin-dependent diabetics in trouble. Two types of diabetics, the type 1 diabetics that are taking insulin, and the type 2 that take a variety of different oral medications, especially the vast number that are available today. This is a much bigger group. It's about 90% of the diabetics. This 8% of the diabetics that take insulin, those are the ones we worry about. Those are the ones that are going to have medical emergencies in your office. These other ones, the ones that are caused by other types of diseases, and the non-insulin dependent diabetics, I basically treat them just like a normal patient. It would be very unusual for them to have any problems. Remember, normal blood sugar, and if the insulin-dependent diabetics coming into your office, you want to know what their blood sugar was this morning. How I remember normal blood sugar is it's normally like 68 to 115. But I can't remember that. I'm stupid. So I remember that it's kind of like blood pressure. Normal blood pressure is 120 over 80, quote, kind of. And so as long as their blood pressure is in the 80 to 120 range, that's kind of a normal blood sugar for the patients to be running. Insulin-dependent diabetics, what they constantly fight is trying to balance out how much insulin they take and how much glucose they eat, how much they take in. And depending on what that balance is going to tell you whether they're hypoglycemic, hyperglycemic, or in a relatively normal range. When we talk about medical emergencies with insulin-dependent diabetics, they all end up with an altered level of consciousness. It doesn't matter if they're too hypoglycemic or too hyperglycemic. Really, the clinical manifestation in the end is basically the same. When we were in dental school, we all had to memorize, is the insulin-dependent diabetic in our office having a hypoglycemic reaction? Are they becoming unconscious because they had a hyperglycemic ketoacidotic coma? And we had to memorize that, right, Joe? We had to memorize that for some test. And in our office, if you can remember that, you're smarter than I am, especially when the patient's becoming unconscious and your adrenaline's high, and you can't remember what's going on. So the thing to remember is the patient that's having diabetic ketoacidosis, which means they have out-of-control diabetes, they're not taking enough insulin, for them to go through and have glycogenolysis, gluconeogenesis, and ketogenesis, all those things that go on, and become unconscious because of a coma, that takes many days to transpire. And long before they become unconscious or become mentally confused, they feel like heck. So this patient that's going into a diabetic ketoacidotic coma feels like heck and cancels their appointment. They're not going to come into your office going, oh, I feel good, and die in your office. On the other hand, the patient that's an insulin-dependent diabetic that has insulin shock can say hi to your front desk, be nice as normal, talk about anything, and die in the back while you're doing the 2.5-hour crown and bridge prep. Okay? So we don't worry about DKA patients. If you have a patient that's in your office that's an insulin-dependent diabetic, and they show any signs of compromise, mental compromise, become unconscious, we treat them as if they're hypoglycemic, they're having an insulin reaction. Don't worry about the other way. If you take someone that is going into DKA because their blood sugar is too high and you give them more sugar, you don't hurt them at all. If you take someone that's having insulin shock and give them more insulin, you'll kill them. Or if you don't give them glucose, you'll kill them. So we always assume they're hypoglycemic. Of course, we can whip out our glucometer and check their blood sugar, but most of us don't have those in our office, even though I advocate in buying one. They're only about $49 today. Patients that are going sour on you, they're hypoglycemic, they have a couple different things going on. The brain can only use glucose to function. That's the only energy source it can use. So you'll have altered cerebral function because there's no glucose available to them. It's all intracellular. And also our body, in order to raise our glucose when we're hypoglycemic, releases a lot of epinephrine. And that's what we see in the patient. That's what's causing the signs or symptoms we see in a patient that is hypoglycemic or having an insulin reaction. The first thing that you'll notice is the patient just has, decreased mentation. They just don't answer your question very quickly, or they seem confused, or they call you by the wrong name, or they think Clinton's a good president, those kind of things. Republicans. Anyway, they have some change in their mood or whatever, something that makes you think that, hey, the squash isn't working exactly right. They might look kind of pale, clammy skin, complain about headache, which is common in hypoglycemia. As they go further into the hypoglycemia, they're going to release a lot of epinephrine, their heart rate will go up, it will actually become an ineffective pump and their blood pressure goes down, they'll become anxious. Hypoglycemic seizures are very common. They might have a little bit of the minor seizure activity and obviously eventually become unconscious. These patients, if they're conscious, what we want to do is we want to restore their blood sugar. And, again, position them wherever they want to be, basic life support. Again, if they're talking to you, telling you they're feeling lightheaded, their airway, breathing, circulation are fine. And we're going to administer an oral anti-hypoglycemic. And like I said, I recommend you buy Instaglucose. You can buy it at Fred Meyer's. I think 3 tubes are about $8. It's much better than using cake icing. I just can't imagine on the stand saying, Well, yeah, I tried to save her life. I squirted some Betty Crocker cake icing in her mouth. Or gave her a Snicker bar. It just doesn't work as well as instant glucose, which is just cherry-flavored honey, basically. And it's just a real good source of glucose. And you give it to the patient, they'll start feeling better fairly quickly. Give them a little bit more. Keep a couple cans of Ensure in your office. Give them some Ensure. And you may or may not want to treat the patient, and you need to decide whether or not they need an escort. Typically, I'd keep them in the office for a while, give them some orange juice and stuff to drink, and normally they can go home on their own. If the episode, despite giving them this, if the episode continues, you want to call 911. Again, as they start deteriorating, and definitely if they become unconscious, it is a life-threatening insulin shock reaction, and you want to call 911 early. And then we're going to give them either D50, 50% dextrose IV, or glucagon, 1 milligram IM. And those we'll see here in just a second. You know, if the oral antihypoglycemics don't work, we're going to kind of step up our action and give them something through an IV if we can. And I know not all of you are ready to start IVs in your office, and that's why glucagon is a good option. Patient becomes unconscious, we're going to put them supine, legs elevated, manage their airway, breathing, circulation. We want to get 911 on the way because it is a life-threatening emergency. And then the drug we truly want to give them is D50, which has to be given IV, not IM. Give it IV, 25 to 30, maybe as much as 50 cc's of this. And within 2 or 3 minutes, the patient, it's amazing how quickly they will respond to that. The other option is to give them glucagon. The problem I don't like about glucagon is it takes about 10 or 15 minutes for the patient really to respond to it, because it depends on liver glycogen stores, and the glycogen has to undergo glycogenolysis and break down, and then the glucose goes up. That's not nearly as rapid as giving them D50. And that's usually what the guys in the EMS guys will give them D50. And in fact, if you go into an emergency room, you're found down unconscious, you'll get D50 in the ER. I mean, that's kind of a normal emergency thing for someone that's unconscious, brought into the ER by ambulance. Maybe you're insulin-dependent diabetic. We don't know it. We just give you D50 automatically. Worst comes to worst, you can always give epinephrine sub-Q to try to transiently raise a patient's blood sugar. Once they're awake, we're going to go ahead and give them some sort of oral carbohydrate, only because that has a longer lasting effect. So you can buy the glucagon for your emergency kit. Comes in a preloaded syringe. Very easy to give because you can give it IM, even though IV would be the method of choice. And again, once the patient becomes conscious, we want to give them either instant glucose or apple juice, whatever. Whatever you buy for your oral carbohydrate, don't buy the no sugar added apple juice. Buy the good stuff. You know, we want them to have glucose, not avoid it. Another thing that causes altered level of consciousness is CVA or stroke. Fortunately, a very infrequent thing in our dental offices, and even when it does happen, we can't do much about it, so I'll go through it relatively quickly just because you probably won't see it, and when you do see it, there isn't much for us to do with it. We can't help these patients much. Different types of strokes. Patients will come in and tell you they had just a little stroke, a small stroke. Usually those are lacunar strokes or lacunar infarctions, very small area of necrosis within the cerebral cortex, and usually they have almost full recovery. And, you know, those are the patients that don't have residual paralysis or something of one side. TIAs, I think everyone is fairly familiar with. What I say a TIA is, it's nothing more than angina of the brain. You know, angina of the chest, we have transient ischemia causing chest pain. Here we have transient ischemia of the brain causing neurological signs and symptoms, but it's completely reversible. There's no tissue death or tissue necrosis that actually occurs. And TIAs usually last in the range of 2 to 10 minutes. It can last longer, but usually they're relatively brief episodes where the patient typically just says, I get kind of weak on one side or kind of dizzy type thing. The strokes we're really talking about are patients that have either a cerebral infarction or an intracerebral hemorrhage. Fortunately, most of them are cerebral infarctions because these we can actually survive. And today, if we get you to the emergency room quick enough, we can actually reverse the damage in many of those patients. The unfortunate thing about intracerebral hemorrhages is probably about 80% of the patients succumb to that disease. It's not very well treated by any mechanisms. But to recognize the patient that's having some sort of a stroke in our office, we know the patients who are going to have them. The patients with chronic hypertension, atrial fibrillation, the patient in chronic atrial fibrillation has a very high tendency to develop clots in their atria, and then when they go out of atrial fibrillation, the atria contract real well, blow the clot down into the ventricle, and then it blows it up to your brain. And so atrial fibrillation is a very high risk thing. Abnormal heart valves and the different risk factors. This is nothing more than an aortic valve. These are the leaflets right there, and this is the other leaflet, and you can see it's not nice and smooth. This is the bacterial endocarditis vegetation that makes the patient very prone to forming these clots that will be shot up into your brain, of course, and cause a stroke. What do we see? The classic signs or symptoms, and it doesn't matter if it's a stroke or a TIA, basically it's the same thing, but normally it's a matter of magnitude. The TIA, just like angina, is usually minor compared to an MI, and a TIA is usually a little bit different in magnitude as compared to a full stroke. Most patients having strokes are actually hypertensive. They'll have some level of alteration of their consciousness from just being a little bit stuporous to being completely out. The classic thing we think about is, they'll have drooping of their facial musculature. They'll have one-sided unilateral hemiparesis or paralysis. They may become totally flaccid on one side. A very common thing is monocular blindness. One eye will become blind, just like that. All of a sudden they lose the sight in one eye. That's a real common thing in patients having TIAs or a stroke. So don't necessarily think it was your injection that, I must have got the, ocular nerve or something. Think about maybe the patient's having a stroke. The facial droop, incontinence, usually if they become unconscious. And another very common thing is they're aphasic. My wife wishes I was that way, I think. But that means you can mentate, but you can't get the words to come out. It's kind of like they're looking at you going, they just can't speak. Aphasia is a very common thing in patients having a stroke. So if we see those things, like I said, unfortunately, all we can really do is, position them comfortably. Basically, we're going to put most of them supine, airway, breathing, circulation, call 911, give them oxygen. As long as the blood pressure is elevated, not low, usually we'll sit them up just a little bit, elevate their head. The reason for that is if they are having an intracerebral hemorrhage, we want to elevate their head because it will diminish the size of the intracerebral hemorrhage. But again, there's not much we can do. If a patient has a history of TIAs and they have these symptoms, very minor symptoms, maybe for 5 minutes, and it goes away, it's just like the patient having angina in your office. It's really not that big of a deal. It's inconvenient as heck and scares the bejeebers out of you, but it's not that big a deal, and they may be able to just go back home. I might call their physician and say, hey, she had a TIA in the office today, and some patients have them all the time, just like they have angina all the time. If it's a new onset episode, new onset TIA, those patients need to be transported to a hospital. And the EMS guys will help you with this once they get there. There's no question about it. Most of them are going to go to the hospital, pretty much. No way you would let someone that you thought was having a stroke get back in their car and drive home. So again, stroke, TIAs, basically we're going to call 911, give them oxygen, monitor their vital signs, and get them the heck out of our office as soon as we can. Another area, seizures, kind of fits under altered level of consciousness in some ways, but it's really a designation all its own because a lot of the patients having seizures aren't unconscious at all, as we all know. There's a variety of types of seizures. And I don't think it's real important for you to know, and this is just a small listing. I mean, there's about, 12 or 14 categories of seizures. But the partial seizures, where maybe they'll just have one arm jerks a little bit when they have a seizure, versus what we classically think of seizures, which are the generalized seizures, the petit mal or absent seizure, or the grand mal seizure. That's usually what we think about in patients that have seizure disorders. And of course, the ultimate seizure is status epilepticus. If you've never stayed at Skamania Lodge up on the Columbia River, you ought to go up there. It's an absolutely gorgeous area, and you won't have a seizure while you're there because it's so relaxing and nice to go. So the actual type of seizure the patient has, the actual name for it, don't worry about. But you need to ask the patient, what type of seizure do you have? What do you do when you have your seizure? And that will help you recognize their seizure coming on. How long does your normal seizure last? How violent do you get? Those kind of questions. Maybe it's a little bit awkward to ask them, but you want to know that. If the patient just, normally does his arm like this when he has a seizure, it'd be nice to know that that's what his seizure disorder is, because in the middle of doing the deal on 12, he starts doing that. You don't know what the heck is going on unless you ask. So if they say they have a seizure disorder, what do you do when you have your seizures? How long do your seizures last? What triggers your seizures? If it's, what's up here, flashing lights, you might want to put sunglasses or blinders on the patient, and be careful as heck as how you adjust your light when you're working on the patient. So know what precipitates their seizure. If it's hypoglycemia, offer them a can of OJ before you work on them. Did you eat lunch today? No, I was rushed to get here. Here's a can of Ensure. Why don't you drink it before we get started? Avoid the triggering factor, and you won't have problems. Probably in the dental office, the biggest reason why we have seizures is the epileptics, the people that do have seizures. And remember, the seizure threshold, the likelihood of them having a seizure, is decreased when they're under increased stress, which, again, in the dental office, these are great patients to pre-medicate with Versed or Valium or Ativan, any of the benzodiazepines, because it raises the seizure threshold significantly. And remember earlier I mentioned that patients that are having syncope may have seizure activity. Don't mistake that for a patient having a grand mal seizure. I know a pilot that lost his pilot's license because the dentist, during the patient having a syncopal episode, the guy kind of went like this just a little bit, and so when the patient woke up from the syncopal episode, the dentist told the patient, "You had a seizure after I gave you your injection today." He lost his commercial pilot's license, because if you're a commercial pilot and you have a seizure, you can't fly planes. And that's a relatively bad thing to have happen. So a little bit of carpal spasm when a patient's having hypoxia is not a seizure. Okay? It's carpal spasm. Don't ever tell them that they had a seizure, because the FAA will jerk their license in a heartbeat. We did get it back for the guy, but it took a lot of testing and a lot of explaining what was going on. Petit mal seizures, the absent seizures usually are a very minor thing, more of an inconvenience than anything. The typical petit mal seizure, lasts for maybe a minute and a half or so, 2 minutes. This lady has just got the blank stare. She's supposedly mimicking for me what her petit mal seizure is. She says, "I just kind of sit there and look at you and don't respond to you." It's kind of like my teenage daughters a little bit. But, that's what she does when she has her petit mal seizure. So ask them what kind of seizure they have. Typically, they just have the blank stare. They may have some automatic behavior, like a real common one is smacking their lips. Or they might stick their tongue out and kind of lick their lips automatically. Or blinking of the eyes is real common. But they are very rapid things and normally don't cause the patient any problem. And in fact, most of those patients have driver's licenses. I mean, it's unusual for them to lose their license over that. If they have a petit mal seizure, basically we're going to stop doing what we're doing and just kind of supportive care. You don't necessarily need to do anything to them. Typically, the seizure will resolve on its own in, a minute and a half or so, a couple minutes. And, I would go ahead and finish their treatment and do whatever I was going to do that day. It's not that big of a deal. If the seizure continues on, unless they tell you that normally I do it for 7 minutes, if it goes on more than 5 minutes, I would consider that maybe something weird is happening here and I want to get the patient out of my office. And so you might consider calling 911 or calling the patient's physician and getting some advice on what to do with the patient. But these patients are usually self-supportive. You don't usually need to do airway, breathing, circulation, or oxygen, or anything else on them. The grand mal seizure is what we normally think about when we talk about seizure disorders. And it kind of occurs in a phase, kind of 3 or 4 phases that the patient goes through. And again, it's important to ask the patient, what do you do when you have your seizure? Typically, the first part of the seizure, the prodrome that occurs right before they actually start the contraction part of it, involves some sort of aura that they will sense. Like they may hear a bell, they may see a bright flash of light, they may taste almonds, and it isn't like they can go, oh, I just tasted almonds, you better get your hands out of my mouth. That's part of their seizure. The abnormal electrical activity is actually already occurring in that patient. So when they first wake up, the last thing they remember is that aura. Boy, I saw a bright flash of light, and boy, I don't know what happened after that. So, but typically there's an aura ahead of time. Some of the times they'll get kind of quiet for a second. And then they go into the pre-ictal. Ictal just means the convulsive part of the seizure. Typically their muscles will tighten up, and if they're standing upright, that's when they fall to the floor. One of the first things that happens is your intercostal muscles, the muscles between your ribs, will all contract and draw your rib cage in. At the same time, your vocal cords will usually be contracting a little bit, and you have that typical epileptic cry where they go, and if you're doing the DO on 12, when they do that, you get the MOD on 13 and 14 done like that. So you just, be aware of that those patients that have seizures usually yell out very frequently when they start to seize. And then they go into the convulsive phase of the seizure. The ictal phase is the medical term for it, where initially they have the tonic part of it, where all their muscles contract, and they will do the head-toe position in your chair. They'll arch their back, and just their head and their feet are touching in your chair. And that will last for, 20 seconds. It's kind of, and they're rigid. And, maybe it goes on 20 or 30 seconds, and then they'll go into the clonic part of the seizure, where actually what happens is the extensor muscles contract and then the flexor muscles contract. And that's the kind of writhing motion that we typically think about when someone is having a seizure. And that typically goes on for a minute, minute and a half, maybe 2 minutes. So within a period of 2 or 3 minutes, the patient goes from being normal to having a massive seizure to going into the post-ictal phase, which is where they kind of lose consciousness. They frequently will become incontinent. They'll wet themselves or do worse things possibly, but usually just incontinence of the bladder. And during the post-ictal phase, how long it takes them to wake up varies a lot. And that's the other thing you want to ask a patient that has ongoing seizures is, after you have your seizure, how violent do you get? Oh, I flail all over. Well, afterwards, how long do you sleep? Oh, for 10 or 15 minutes, I'm totally out. That's nice to know, because after they have their seizure, 10 or 15 minutes and you're the doctor, that is 2.5 hours. But if you know it's normal for the patient, it won't bother you. On the other hand, if normally after they have their seizure, they, within 2 or 3 minutes are waking up, that's their normal seizure. If they have a seizure in your office where at 2 or 3 minutes they're still out, at 5 minutes they're out, at 10 minutes they're out, I'm calling 911. Because that patient's having a more violent, significant seizure, and we probably need to send them to the emergency room rather than send them home. So it's important to know exactly what this is for your patient. And it is kind of uncomfortable in some ways to ask those questions. We're having a station break.